Good morning to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Satish V. Kadikar. Sir is MD, DM, DNBE, FIAN, FICP, FAMS, FRCP, London, Dean and Professor and the Head of Department of Neurology at Bombay Hospital Institute of Medical Science, Mumbai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is treatable neuropathies in clinical practice. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you very much. And thanks also for asking me to be here on this platform. I know it's a very reputed platform and a lot of viewers are on the platform. So the topic that we have taken today is treatable neuropathies in clinical practice. See, in clinical practice, the focus of the whole activity is towards treatable things and not to miss any of them. As you know, peripheral neuropathies have so many different causes that it is important that the medical doctors know and remember the treatable ones and they don't miss them. That's why we chose this topic. Now, to introduce peripheral neuropathies to the audience, because I know that there is a mixed audience, the classifications of peripheral neuropathies run in pages and pages in textbook of neuropathies, textbook of neurology. But for practicing doctors, I think we can simplify it to a great extent and say that neuropathies are basically of three types. Mononeuropathies, meaning thereby one nerve is affected. Mononeuropathy multiplex, meaning thereby multiple nerves are affected in various parts of the body. And polyneuropathy, meaning all the nerves are affected. So for the practicing doctor who sees neuropathies in the consulting room, he divides them into three: mononeuropathy, mononeuritis multiplex, and polyneuropathy. Very briefly, we will touch upon the mononeuropathies, which are actually entrapment syndromes. And the common entrapment syndromes are the carpal tunnel syndrome, the median entrapment at the wrist, the ulnar at the elbow, and tarsal tunnel syndrome, and some such mononeuropathies. So mononeuropathies result from trauma, pressure, and some endocrinopathies like thyroid diseases or diabetes makes people susceptible for getting mononeuropathies. These are the ones that I have written down, which are common: carpal tunnel, ulnar at elbow, lateral popliteal at fibula, and sometimes the anterior introitius at elbow is not all that common. These are important to recognize because their treatments are comparatively simple. Carpal tunnel syndrome might do well with conservative treatment for a while and might require surgical option. Ulnar at the elbow is usually due to constant pressure on the bone, and the lateral popliteal at fibula gets caught when people lose weight, have chronic diseases, and these are all amenable to therapy. Let's spend a little time on mononeuritis multiplex, meaning nerve by nerve involvement of nerves at random in the body. Now, mononeuropathies are easy to diagnose. Polyneuropathies are easy to diagnose. But mononeuritis multiplex, it is the physician's job to pull it out of hiding. So you have to focus on early events. For example, you ask a patient, how did your problem start? And the patient will say, doctor, there was this finger affected, then the second finger affected, then all fingers affected. And you can detect a nerve by nerve involvement if you focus on the early events. If you do that, you start feeling that, look, this is not a polyneuropathy. This is something where one nerve, then other nerve is getting involved, and it's mononeuritis multiplex. Now, pain is a dominant feature of some of the mononeuritis multiplex. Now, why is it important to make a diagnosis of mononeuritis multiplex? Because the set of conditions that produce them are few and they are treatable. The most important, even today in India, is Hansen's disease. Then there is diabetes mellitus and vasculitis. So two large groups of conditions when you see mononeuritis multiplex clinically, Hansen's disease and vasculitis, like polyarteritis nodosa, rheumatoid arthritis, lupus, mixed connective tissue disorders, and sometimes some forms of demyelinating neuropathies can present like that. Now, I want to spend a little time on Hansen's disease. Hansen's disease has not gone away. From time to time in our neurology clinics or the government hospitals, as well as the private hospital, we see leprosy and neurological leprosy. Now, let's all remember that even though leprosy is a disease treated by the dermatologist and is considered to be a skin disease, there is really no leprosy without neural involvement. Because if you think about it, the anesthetic patch, which is the cardinal manifestation of leprosy, the moment you say anesthetic patch, you are talking about involvement of the intradermal nerves. So leprosy is a disease of the nerves and the skin. And sometimes the skin component may be missing and there may only be a neurological component. Such cases need to be really sought out. And I'll show you one case. From time to time in between, I'll show you cases so that the presentation becomes interesting. This was a 50-year-old man. He had bilateral calf pains for 3 years. 2.5 years ago, numbness of both feet. And the expression he used was, my nerves are ballooning out and they'll burst. 2 years ago, similar complaints started in the upper limbs without any symptoms around the mouth. He was investigated thoroughly and no particular cause could be ascertained. 2 months before he presented to our institute, he had noticed swelling and redness of both feet without any pain, and there was burning. After immersion in warm saline, there was a little relief of numbness. Then one curious thing happened, that while holding his hot cup of tea, he burnt his fingers and couldn't appreciate the heat. This shocked him. And here as you can see, on the middle finger, you can see the burn marks on both sides where he was holding the cup. Patient was a known diabetic. Now, let me ask all of you a question. Could this be a diabetic neuropathy? The answer is it is less likely to be a diabetic neuropathy because it has affected hands as well as feet. And you hardly ever see burnt hands in a diabetic neuropathy. So when you see burnt hands and heat sensation not being perceived, you start thinking of leprosy. And another condition that you see is syringomyelia. So to cut a long story short, notice the sensory system at the bottom of the slide. He had severe loss of pain, fine touch, and temperature below the elbows, below the knees, which is very widespread. And the vibration was comparatively mildly affected in the mid-tibial shin. The position sense was normal. So we thought, what are we dealing with? So we thought, is this a leprosy? And we went with the skin examination. The skin examination showed hypopigmented patch over right knee, which we biopsied, thinking that we may find leprosy. but the biopsy only showed a scar tissue. So really now we had a patient with severe symptomatic distal small fiber neuropathy with very mild motor and reflex involvement, and we investigated it. The vasculitic workup was normal, B12 was normal, HIV was negative, CSF was normal, and electrophysiology showed only H reflex to be abnormal. We will leave it for the time being. So we did not have any choice but to do a nerve biopsy. Now, nerve biopsy is done only rarely in today's time. And what the sural nerve biopsy actually, the radial nerve biopsy actually showed, those of you who are familiar with pathology will see that the whole nerve is inflamed and there are inflammatory cells everywhere. And you can see some granulomas on all parts of the nerves. And this is a higher power picture showing you granulomas. And when you do, this is the Phyte Farraco stain, which shows the lepra bacilli, which are the cigar-shaped bacilli that you see. And on electron microscopy, you see live bacilli in the nerve. So this patient had a pure neuritic leprosy, which was borderline lepromatous type without any skin lesions. And that makes the diagnosis difficult. So within the group of mononeuritis multiplex, which consists of two important differentials, leprosy and vasculitis, please remember leprosy. Look at the skin everywhere. The skin lesions may be on the interscapular region, back, buttocks. So unless you know where to look for them, you may not find them. And there will be also patients in whom there will be no skin changes and there will only be pure neuritic leprosy. So we have seen mononeuritis multiplex, and we have seen the involvement of only the nerves due to leprosy, which is a very treatable neuropathy. And please don't forget. Now, from mononeuritis multiplex, we go to polyneuropathy. And polyneuropathies can be due to an axonal problem or a myelin problem. Axonal problems usually produce are due to toxic and metabolic, and myelin problems are usually due to immunological reasons. So I'm again going to take a case because a common cause of immunological myelin neuropathies is Guillain-Barré syndrome, and we all see it from time to time. So this is a 33-year-old male who came with tingling numbness in soles and palms for 15 days, fatigue and calf pains of 4 days, and difficulty in climbing stairs for 2 days. He had loose motions for 1 day, 15 days prior to the onset of symptoms. He was a chronic smoker, took mixed diet, and had a right inguinal swelling. So loose motions for 1 day, then a gap of 2 weeks, and then he develops tingling numbness in palms and soles, fatigue, and some weakness in climbing stairs. So this is exactly the history of AIDP or a Guillain-Barré syndrome, where there is an infection, there is a gap, and then there is a rapid onset neuropathy. Now, in 1/3 of people, you may not see any infection. It may straight be a neuropathy. So we examined him. There was mild weakness of the hand grip and hip girdle, decreased touch and pinprick over soles and dorsum of the feet, and decreased pinprick and touch at tips of fingers. So it was a sensory motor neuropathy. Now I'm taking this case so that we can learn along the way. If you remember your GB syndrome patients, the dominant part is the weakness. They are motor syndromes. Patients complain of aches and pains and tingling, but sensory findings are not very common. They can happen. So in this patient, there were sensory findings and generalized areflexia and motor weakness. So it still fitted within the umbrella diagnosis of GB syndrome, even though sensory findings are not all that common. So we made a provisional diagnosis of GB syndrome, or acute inflammatory demyelinating polyneuropathy. What is the differential diagnosis? It's periodic paralysis, poliomyelitis, botulism, tick paralysis. Now, as you can see, all of these are much more uncommon as compared to GB syndrome. Periodic paralysis, people get attacks again and again. Polio is becoming distinctly less common, but there are other polio-like viruses that are still in the air. Botulism is not so common in India because we do not use canned food. And tick paralysis also is quite uncommon, but you can see it in rural setting in people who are bitten by the ticks. So this differential diagnosis is important to know. We investigated him. Bloods were all right. Electrophysiology, let us go over it because the forum is not for electrophysiology. But the conclusion is that there was a widespread multifocal sensory motor demyelinating peripheral neuropathy, which went hand in hand with GB syndrome. See the words widespread, multifocal, meaning patchy and in various areas, sensory motor demyelinating peripheral neuropathy. CSF showed albuminocytological dissociation. Now, how do you treat GB syndrome? That's a very common treatable neuropathy or a radiculoneuropathy. It's treated with a course of intravenous immunoglobulins or plasma exchange, depending on the patient profile. If the patient is very young or very old, then you do not choose plasma exchange. You would choose intravenous immunoglobulins over plasma exchange. There are also some other indications where you won't use IVIG. But therapeutic efficacy-wise, IVIG and plasma exchange stand shoulder to shoulder in treatment of GB syndrome. And they are both effective if you start early. So whom do you treat with IVIG or steroids? People who have ambulatory difficulty, people where the power in some part of the body is grade 3 and less, and people in whom the duration is less than 7 to 10 days. These are the ones where the progress of the illness can be thwarted by using these agents. If you have a very mild GB syndrome, then whether to treat it with these drugs or not is a question, and there isn't too much evidence to that. So this patient responded to IVIG and was better, but in a couple of weeks came back to the hospital with a left lateral rectus palsy, proptosis, severe sensory ataxia, severe weakness, and facial weakness as well. So see now what has happened. Do you get eye movement abnormalities in GB syndrome? You don't. Eye movements are preserved in most of the GBS patients. So you got a proptosis and you got a lateral rectus palsy. Do you get a sensory ataxia in GBS? Really not. As I told you, the standard garden variety GBS is a motor syndrome with very little sensory ataxia. So this patient now was going outside the bounds of the GB syndrome because he had cranial nerve palsies of the eyes and he had a severe sensory ataxia. So we investigated him further and we took that inguinal swelling, which was a lymph node, out, and it actually showed Reed-Sternberg cells suggestive of non-Hodgkin lymphoma. So what we were actually seeing was a paraneoplastic GB syndrome in a patient who had a stage 3 Hodgkin lymphoma. Now, the case is unusual, but I thought we'll cover GBS with this case and also keep it in mind that a GBS may itself be a manifestation of something else. So we first saw leprosy, then we saw GBS. GBS you'll encounter again and again. So diagnostic criteria are important, which are clinical and electrophysiological. If you get them early and they are severe enough, then you would treat them with AIDP, with IVIG or plasma exchange. And then, of course, ventilatory care if required. Right. So as I was telling you, polyneuropathies are either due to myelin problem or an axon problem or a neuron problem. Myelin problem we saw, which is GBS, which is usually immune. And then there is a slow form of GBS. Whatever happens in GBS in 1 week happens in a month or 2 months in a form called chronic inflammatory demyelinating neuropathy. If time permits, we'll see a little bit of it. Now let's see the axonopathies. Axonopathies are also very peculiar diseases where they follow a principle called length dependency. Meaning thereby, if you look at the axon of, say, sciatic nerve, it's 45 centimeters long and thin like our hair. So how does the axon get its nourishment? By a process of axonal flow which goes from the neuron step by step to the distal part of the axon. Then it turns around. The wastes are carried back by the process of reverse axonal flow. So you can see that just by the physical properties of the axon, it is difficult for the neuron to send nutrients to the distal part of the axon and carry wastes back from the distal portion of the axon. So longer the axon, more likely that it will suffer. This is called principle of length dependency. So axonopathies result in symmetrical sensory motor areflexic weakness, which starts in the lower limbs because lower limbs are longer than the upper limbs, starts in both lower limbs at the same time because they are of the same length, and then it centripetally goes on and then affects the upper limbs. It's sensory motor and areflex. So this is the principle of length dependency. So when you take that history and know that it's a length dependent neuropathy, you know that it will be an axonopathy. And what is the importance? Axonopathies are due to toxins and deficiencies. So you're directly on to two big causative things. So I would like to spend a little time on toxic neuropathies because I feel that they're slightly under-recognized. India is a country where different types of contemporary styles of medicine are going on. And you have Ayurvedic medicine, you have Unani medicine, you have homeopathy, you have Siddha medicine. And some of these medical styles bring in the metals in their armamentarium. So whatever is a bhasma in Ayurveda is a metallic oxide. And Trivanga bhasma is very common, which is a combination of arsenic, lead, and mercury. Similarly, gold is used, other metals are used. Gold is particularly used for joint problems. So when these metals go into the system, metallic oxides go into the system, such as arsenic, lead, and mercury, they can lead to a painful sensory neuropathy with skin and nail changes. So be on the lookout for alternative medicines. What has the person been taking? Take a detailed history, and you may find that there is an axonal neuropathy with skin and nail changes. So the key words for toxic neuropathy are skin and nail changes and axonal painful peripheral neuropathy. So this is a 46-year-old man, diabetic and hypertensive, who developed one-day watery diarrhea and admitted with my good friend, who is a GI doctor. They did the hanging drop preparation. It was not cholera. The watery diarrhea subsided and they sent him home. 7 days later, he came back to the GI doctor saying that I got burning of palms and soles. So there is a 1-day diarrhea, there is a 7-day gap, and then there is burning of palms and soles. Is this GBS? It's unlikely to be GBS because there is a burning as a symptom. Tingling, numbness, and pain you can sometimes see in GBS, but burning you don't see. So he phoned me and I said, you send him to me. Let me see what's happening. Examination showed that he was extremely dysesthetic and he was not allowing me to touch the soles or the palms. Then he went on to develop gradual motor weakness, areflexia, and then he developed this hyperkeratosis. As you can see here, there is a hyperkeratosis of the soles. And this patient had taken arsenic as an aphrodisiac from an Ayurvedic doctor. And because the result was not satisfactory, he overdid it. And he overdid it. And then landed up in acute arsenical poisoning, which was diarrhea. Then he settled down, and then a neuropathy came. So you can get hyperkeratosis of palms and soles, epithelial changes, and you can get a painful lung-dependent sensory motor neuropathy in arsenic poisoning. On the systemic side, these people have weight loss, general ill health, and they can have measles. Second toxin that you see from time to time is lead, either as Ayurvedic medicine or occupational in battery chargers. See, previously lead was in paints. So the classical history in the older textbooks was children taking the flake of paint out from home and eating it, or a painter who's mixing the paint and working gets a wrist drop. But now paints are acrylic. So now the history is battery changes, environmental toxin, such as people standing on the main road like policemen, people living close to highways, and people who are in the occupation such as battery charging. Lead is a motor neuropathy. Like arsenic is a sensory neuropathy, lead is a motor neuropathy. And this is one of my patients with the Mees lines. This is quite an old photograph taken on a camera when cameras had films. And you can see the horizontal lines, which are Mees lines. Right. When there is too much of toxicity, you need to chelate either arsenic or lead. Thallium is the third one, which is common because it's part of the rodenticides and it's easily available. And people put this as preservatives in the grain that they store at home. And if the grain is ground with this, they can get a neuropathy. But these people have loss of hair, alopecia. So hyperkeratosis, Mees lines, alopecia. Mercury toxicity is rare. And they get a cerebral ataxia and red palms, acrodynia. So that's the toxic group. Within the toxic group, you also have liver cell failure, kidney failure. Those neuropathies are very similar, axon. Second is the vitamin deficiency, toxic and deficiency. So deficiency is B12 deficiency, which is very common in India because we have vegetarians, we have vegans, we have people with abdominal tuberculosis, and it usually produces a sensory ataxia. But the key word is that it produces a combination of spinal cord disease and nerve disease. It's important to recognize it quickly because you have now medicines available which give very satisfactory outcome. As you know, if you give one injection of 1,000 micrograms, for a whole month B12 is filled. But please also remember that B12 doesn't work unless there is folic acid. So always supplement it with folic acid. So B12 deficiency can produce a distal neuropathy, which is sensory. It can produce a myeloneuropathy, spinal cord and peripheral nerve. It can also produce a cerebral ataxia. It can also produce cognitive changes. So B12 goes everywhere. So it's usually not a pure neuropathy. It's often a myeloneuropathy. Then we'll touch upon diabetic neuropathy. 48-year-old diabetic patient, not too careful with his food and medicines, 3 months of burning feet, cannot tolerate footwear and fan, sleep got disturbed. Severe hyperesthesia over soles, but could feel touch pin temperature normally, joint position and vibrations are normal, and ankle jerks were present. So see this presentation. Tremendous symptoms, dysesthesia. You go to examine, there is very little to find. Touch is normal, pinprick normal, temperature normal, joint position normal, vibration normal, motor strength normal, ankle jerk present. So you will start wondering, oh, this patient has so many symptoms, but has got no findings. What is happening? This is a classic presentation of a small fiber neuropathy, where patients have a lot of symptoms, but in the early phases, you may not get any signs. Also, please remember that if you send such a patient to electrophysiology, because you are not finding any findings, electrophysiologists will also not find any findings, because small fiber examination is not easy on the electrophysiology. What are the common causes of small fiber neuropathy? Diabetes mellitus, diabetes mellitus, diabetes mellitus, vasculitis, then the rare ones, such as cryoglobulinemia, Fabry's disease, and Tangier disease. So people have positive symptoms. And in diabetes, you see this all the time. Usually, you see it in people who have established diabetes for a while, but you can also see it in people who are diagnosed as diabetic because of the neuropathy. So it doesn't necessarily um, follow the duration and the control of the diabetes. Yeah. Right. So that's about the diabetes. And amongst the rare causes, I think um, it's good to show some rare situations as well. This is Fabry's disease, and these are the keratotic skin lesions that you see in the around the umbilicus of this boy. This boy was sent to us by dermatology department after having made the diagnosis of Fabry's disease for a stroke-like event. Lastly, I think we will deal a little bit with pain in neuropathies, because that's an important aspect of treatable neuropathies. So the first line therapy today is either gabapentin or pregabalin. Now, both drugs are very similar, but they are in market because they have been approved for different indications, one for epilepsy and one for neuropathy pain. So gabapentin and pregabalin or tricyclic antidepressant is the first line of therapy for pain in neuropathy. Now, it is very important to start both these drugs very tiny doses, because as we all know, our Indian patients do not tolerate big doses that the Caucasians can. And if you start a big dose and some side effect comes, then they are not willing to take that drug and you lost a good drug. So generally, I start gabapentin 100 milligram twice a day or 50 milligram twice a day if it's a very frail individual, and gradually build up. Similarly, pregabalin 75 milligram or 37.5 milligram is my starting dose, which is a little smaller than what most people will use, and then slowly go on increasing. When you choose a drug, you have to tell the patient that it is going to be at least a few weeks before we can decide whether this medicine is helping you or not helping. Otherwise, in a week's time, if the patient comes back and says, "Oh, I'm not better, please change to something," then you can change only once or twice because your drugs are limited and then nothing will be left. So choose one drug, start low dose, and go slowly, giving the idea to the patient that it will take at least few weeks before he and you know that it is working for him. So start with pregabalin, gabapentin. If there is any contraindication, then you can use amitriptyline or nortriptyline or imipramine. Second line is duloxetine and venlafaxine. Again, duloxetine I have found to be a very effective drug, but you need to use it with, again, small doses. So 20 milligram once a day, slowly go on increasing. You can go up to 30 milligram 3 times a day in big built individuals. It is considered to be safer than the tricyclic antidepressants. So in my armamentarium, it is gabapentin first, duloxetine second. Thirdly, I will use a nortriptyline or I'll combine a nortriptyline with it. And fourth, maybe clonazepam, 0.5 milligram once a day at night, and then gradually increase if needed. Then there are a whole lot of second line drugs which are like local capsaicin, mexiletine, SSRIs, topiramate. But the strength of evidence is not all that much. Carbamazepine was used a lot before these drugs became available, but now you don't use it too much. In selected cases, you go to opioids because obviously your worry is about the people getting used to it. So this was 2 or 3 years ago when a sort of on-ground survey of what people use was done. And gabapentin is outstandingly common, followed by tricyclics and duloxetine. Surprisingly, opioids are gaining a big share. So I think we have used up the time. We'll stop here. So I'll recapitulate. Basically, neuropathies have so many different causes. Out of them, quite a few are treatable. You need to pick them out. So firstly, you divide neuropathies into mononeuropathy, mononeuritis multiplex, and polyneuropathy. In mononeuropathy, the common ones, the carpal tunnel syndrome, lateral popliteal fibula, and ulnar at elbow are quite amenable to therapy. In mononeuritis multiplex, please don't forget leprosy. Don't forget that leprosy can affect only nerves and not the skin, or the skin may be so little that you may not find it. Vasculitis is the other treatable cause of mononeuritis multiplex. So you look at mononeuropathies, look at mononeuritis multiplex, then when you come to polyneuropathy, you divide them into axonopathies, myelinopathies. Myelinopathies are basically immunological, and two common examples are GB syndrome and chronic inflammatory demyelinating neuropathy. Both are very treatable to immunotherapy. For GB syndrome, you have the IVIG and plasma exchange. For CIDP, you can also use corticosteroids along with other immunosuppressants. And there are now very many forms of CIDPs, but that's postgraduate discussion material. And in axonopathies, there are toxic diseases. Don't forget the Ayurvedic medicines. Don't forget the heavy metals. Don't forget organ failures like liver, kidney. And deficiency diseases. You have mainly the B12. You can have pyridoxine in people who are taking TB, and so on and so forth. Then lastly, we discussed diabetic as a toxic metabolic, and we looked at pain as a feature. And we discussed what are the methods in which you can alleviate the pain. And we decided to stop there because it's a very huge topic and we've used up our time. So thank you very much for paying attention to what I'm saying. And if there are any questions, I'm quite happy to take it. Thank you very much.
Thank you so much, sir, for your wonderful presentation. So we do have some questions if you'd like to take that up.
Yes.
So, sir, the first question is, what are the biggest challenges you face in treating neuropathy patients, and how do you overcome them?
Sorry, I didn't get
Get
the
the
question.
sure, sure. So, sir, the question was, what are the biggest challenges you face in the treating neuropathy patient, and how do you overcome them?
Challenges.
Yes, sir.
See, first challenge is making a diagnosis. First challenge is making a diagnosis because neuropathies have so many different causes that as a medical doctor, your first challenge is to try and find out what is the diagnosis. In best of hands, in best of clinics, about 2/3 patients can be diagnosed with accurate etiology. Remaining, you may not be able to. So that's one challenge, and you may require a lot of investigation. Second challenge is managing the therapy. Like if you're taking, say, immunotherapy, you started off, the patient is better, how long to keep it, or how to monitor, how to make sure that there are no side effects of what is happening. So second challenge is finding the right treatment and managing it over the long term. Third is to prevent the complications in people in whom you don't know what the etiology is. And that sometimes can be difficult because you can get trophic ulcers, Charcot joints, disabilities, long-term disabilities. So those in general are the challenges, but it's a broad question. So the answer will have to be broad. Yeah.
Thank you, sir. There is another question. What are the red flags in neuropathy that may indicate a more serious underlying condition?
That may indicate.
That may indicate a more serious underlying condition.
Right. Right. See, frankly, every neuropathy that you see, you have got to be a little alert because it may be a manifestation of something underlying. But if you see a neuropathy that is affecting the upper limbs as well as the lower limbs, a neuropathy that has autonomic dysfunction, a neuropathy that is disabling, you got to be very hard on trying to find out is there any underlying. So that one would think is a red flag. Yeah.
So there's one last question. How do treatment approaches differ between diabetic neuropathy and other type of neuropathy?
Treatment approaches don't differ because treatment approach basically depends on what is the diagnosis that you have made. So diabetic neuropathy is a multifactorial neuropathy. You got the metabolic theory, you have got the ischemic theory. So in that sense, depending on what your patient has got, what sort of diabetes has he got, what is the diabetic control, you need to pan out your treatment. One thing I would like to mention that in clinical practice, I always see that once a diagnosis of diabetes has been made, people go very severe on the diabetes control. And sometimes their doctors also go on a very severe diabetes control mode. So they make changes in their diet, they start exercising, they also start medication, sometimes insulin. And the diabetes control becomes so tight that another neuropathy comes up. When you suddenly tighten the diabetes very quickly, insulin neuritis or a treatment neuropathy emerges. And that I see in Indian clinical practice again and again. So one of my requests is not to be too severe on the diabetic control as the doctor after you made the diagnosis. If you go slow and steady over a few months' time, your patient will go over the hyperglycemia without landing into a complication of the treatment. Thank you.
Thank you so much, sir, for answering all our questions, sir. Before concluding, sir, any last remarks from you?
No, I just want to say that neuropathy is a slightly neglected area. And while in neurology, there are lots of seminars on epilepsies and stroke and multiple sclerosis and Parkinson's disease, um, physicians at large, we don't recognize that neuropathy is a disability for patients. And in one survey, almost 46% of neurological illnesses had a component of neuropathy. So this is something that we need to pay attention to and make sure that that doesn't get out of our, doesn't slip out of our hands. Thank you very much.
Thank you so much, sir, for joining us today. And with your permission, I would like to conclude today's session. Thank you.
Thank you. Thank you very much for asking me to be here. I enjoyed it. And if there are any questions coming up later on, I'll be also quite